because waiting for the surface antigen loss may take decades with the current available drugs. There is a look and new trends to withdraw the treatment, safe discontinuation to accelerate surface antigen loss, to get the benefits of higher surface antigen loss rates, and together with inactive carrier state or long term of therapy in about 50% of cases. How can we get this induction of safe discontinuation of nucleoside analogues in E antigen negative chronic hepatitis B? By looking at the predictors of the surface antigen loss with nucleoside analog withdrawal. We have to fulfill as much as we can this criteria. The quantitative surface antigen at end of treatment, which is the most consistent up to now available marker, but the thresholds vary between less than 100 in the Asian population and less than 1,000 in the Caucasian patients, most frequently identified. In addition, the quantitative surface antigen at the baseline and the more than one log decrease of quantitative surface antigen early on treatment. It has to be stressed here that the duration of nucleoside analog therapy and the consolidation has been found in multivariate analysis not significant. The most important factors are the surface antigen quantification at the baseline, at the end of therapy, and the rapid decrease on therapy. So the use of the quantitative surface antigen as a marker of safe discontinuation of nucleoside analogues in hepatitis B, antigen chronic hepatitis B. We can look accordingly to the Asian criteria here, the HBsAg guidelines, the quantitative surface antigen less than 100 and more than 1,000 and the in between. If it is more than 1,000, don't stop treatment. And if it is between 100 and 1,000, there is a possibility here to add on or switch to interferon, regulated interferon for 1 year or 2 years in order to secure the discontinuation of the nucleoside analogues to cover and prevent the flare. While the actual safe discontinuation may be hoped to when the surface antigen is less than 100, provided the following criteria should be fulfilled. So we can follow this algorithm whenever we need this under strict considerations. In E antigen negative chronic hepatitis B, prolonged viral suppression. If the patient is cirrhotic, we have to continue the nucleoside analog. And again, if the patient, if the post-treatment monitoring is not guaranteed, we have to continue the nucleoside analog. But if these two are fulfilled, there is no cirrhosis, and the post-treatment monitoring is guaranteed, we look for this quantitative surface antigen less than 100. If the three are fulfilled, at this time we can stop the nucleoside analogues and monitor. But as I have mentioned, if any of them is not fulfilled, we have to continue the treatment. Lately, there is a stopping rules for discontinuation of nucleoside analogues has been mentioned. And the nucleoside analog should be stopped only in highly selected patients, well monitored, without cirrhosis or F3. This is new. The patients should be F2 only, or in the settings of clinical trials. The withdrawal of the nucleoside analogues may be considered in patients fulfilling all the stopping rules. As I have mentioned, the surface antigen less than 100 and have no significant liver fibrosis less than what the F3 less, comply strictly to the monitoring schedule and are willing to receive or pay for long-term medications. No randomized controlled studies should be conducted to find the best candidates for treatment discontinuation with the highest possibility of achieving functional cure and the lowest rate of disease flare. And thank you very much.